Dear students, welcome back. In the previous session, we have discussed about wrist complex. Now, in this session, we are going to discuss about the hip complex. In the hip complex, we are going to study hip joint. So, in this chapter, you have to study the structure of the hip joint, function of the hip joint. In the structure of hip joint, I'll have the two different kinds of articular surfaces and some modifications in the articular surfaces and their angles, which mainly responsible for the stability of the hip joints. Okay, and also in the case of functions, how this hip joint is related with the other joints like spine and knee joints. So like that you have to analyze the things. And also in this chapter you are going to study about the bilateral stance and unilateral stance. What are the forces requiring for this bilateral stance and unilateral stances, and you have to calculate how much weight is taken up by each joints. Like that you have to know in this chapter. And also the hip joint pathology also we are going to discuss in this chapter. Okay, now we'll start with the hip joint. And this hip joint has some similar features with that of the shoulder joint also. Why? Because the hip joint or a coxofemoral joint is the articulation of the acetabulum with that of the head of the femur. So head of the femur is articulate with the acetabulum. Okay, and these are the two segments form a diarthrodial joint called as synovial joint, which is made up of which is a variety of ball and socket joint, and these will have a 3 degree of freedom of motion. One is flexion, extension in sagittal plane, okay, and abduction and adduction in the coronal plane, and the medial rotation and the lateral rotation in the transverse plane. These are the movements which are taking place at the hip joint, that is 3 degree motion. So the same type of features is also seen in the shoulder complex also. So both the hip joint and the shoulder joint in structure wise both are forming a diarthrodial and ball and socket type of variety of joints. This includes the same 3 degree of freedom also. But if you see, the major role of the shoulder complex in the upper extremity is to provide a stable base on which a wide range of mobility for the hand can be used. Okay, and this shoulder complex structure mainly works in the form of open kinematic chain. But in the case of hip joint, the primary function of the hip joint is to support the weight of the head, okay, weight of the head, arms and the trunk. It mainly used. So these weight are transmitted to the lower joint. Lower joint, that means the hip. The hip joint is mainly providing support to the weight of head, arms and trunk. Simply we can call it as HAT. Okay, not both in static erect posture, so, and also in dynamic postures such as ambulation, running and stair climbing, like that. So in both the cases, in static erect posture as well as dynamic postures, this hip joint is giving support to the weight of the head and the trunk. Okay. So that means the hip joint mainly or primarily to serve as its weight bearing functions. It mainly serves as its weight bearing function, and normally it is worked mainly as when it is giving support to all these weights of upper trunk and all. So the hip joint is worked in a closed kinematic chain. Okay. If it also, the structure of the hip joint is also designed in such a way that it can move the foot through space. It can move the foot through space in an open kinematic chain also. Okay. So as I have already mentioned earlier, that this chapter mainly involves the function of the hip joint, that is mainly the weight bearing function, and also its weight bearing responses during unilateral stance, bilateral stance, and during movements also. Okay. And also how this hip joint is interacted with that of other joints like spine and lower extremities. So all these things we are going to discuss in this chapter. And now we will move on to the structure of the joint, structure of the hip joint. So the hip joint is having a proximal articular surface and distal articular surface, and the proximal articular surface is mainly formed by the acetabulum, and distal articular surface is mainly by the head of the femur, isn't it? So now we will see in detail about the proximal articular surface. The proximal articular surface is a cup-like concave socket. So here you can find the cup-like concave socket of the hip joint is called as acetabulum, which is located on the lateral aspect of the pelvic bone or hip bone or innominate bone. So this innominate bone mainly forms the pelvis, and this innominate bone is made up of with three bones. One is the ilium, ischium, and pubis, and all these three bones contribute in the structure of the acetabulum. So 1/5 of this pubis forms the acetabulum, 2/5 of ischium forms the acetabulum, and the remaining part of the acetabulum is formed by the ilium. Okay. Until full ossification of this pelvic bone occurs between 20 and 25 years of age, the separate segments of the acetabulum may remain visible. So the separation of the acetabulum is clearly seen in the radiographs also. Okay. Now, so in the acetabulum, the periphery of the acetabulum is called as lunar surface, which is covered by hyaline cartilage, So the horseshoe shaped area of cartilage articulates with the head of the femur. So here you can find this cartilage also. So this horseshoe shaped cartilage articulates with the head of the femur, and it allows for contact stress to be uniformly distributed. The inferior aspect of the lunate surface, normally the acetabulum is like this. So here if you can see the inferior surface of the lunate acetabulum is interrupted by a notch. So this notch is called as acetabular notch, and this acetabular notch is connected by a transverse acetabular ligament. Normally this acetabular ligament, which are the parts of this acetabulum labrum, okay, that we will see now. So which connects the two ends of the horseshoe. So, and it forms a notch. So because of this transverse acetabular ligament, it makes a notch like structure. So here this thing, so here a notch is formed. So through this notch, all the major blood vessels which pass through the central and deepest portion of the acetabulum, okay, which is called as the deepest portion of the acetabulum is called as acetabular fossa. Okay, next, and the acetabular fossa is non-articular. Actually, the deepest portion is non-articular. The femoral head does not contact the surface. The acetabular fossa contains fibroelastic fat covered with synovial membrane. Okay, so this acetabulum appears to be spherical only at the upper margins of the acetabulum, which is having a true circular shape. Okay, the acetabulum is positioned laterally with an inferior and anterior tilt. So the acetabulum, which is placed on the lateral side, it is having an inferior and anterior tilt is present in the acetabulum. So the opening of the acetabulum is approximately laterally inclined 50 degrees. So laterally, which is inclined 50 degrees, and anteriorly it is rotated by 20 degrees, and tilting also, anteriorly tilted also 20 degrees. Okay, so if you can see all these variations in the X-ray, yes. So on the lateral side, it is 50 degrees angulation. It is having an 50 degrees of inclination, we can call it as. And the acetabulum is anteriorly rotated 20 degrees and also tilted. This anteriorly, the acetabulum is tilted 20 degrees. So all these tilts we can observe in different planes. We can't see in coronal plane as all the tilts, all the inclination. So each inclination we can observe in different planes. For example, the lateral inclination we can observe in coronal plane. So this tilt we can see, this is the coronal plane. So we can find this coronal picture here, coronal tilt. So anteriorly we can see in the transverse plane, and anteriorly tilted we are going to see in the sagittal plane. So such kind of position of acetabulum is present, and the depth of the acetabulum can be calculated by an angle called as center edge of angle. So this angle is drawn. How this angle is formed means, so here a line which is connecting, so the center edge angle of the acetabulum is formed between a vertical line through the center of the femoral head and a line connecting to the bony edge of the acetabulum. Okay, this is called central edge angle Normally, the depth of the acetabulum is formed by the acetabulum, acetabular labrum, which also increases the depth. So, the acetabulum labrum is a structure which is made up of fibrocartilage and which is rimmed by a ring of wedge shaped, which is made up of fibrocartilage around the acetabulum. The labrum of the hip to a large extent is same as that of the meniscus of the knee, and also the labrum, we have seen glenoid labrum of the glenohumeral joint. Okay, so the need for stability at the hip joint is very much necessary, and it helps in the stability of the hip joint. If you see the attachments, the labrum is attached to the periphery of the acetabulum by a zone of calcified cartilage with a well-defined tide mark is seen. The acetabular labrum not only deepens the socket but also increases the concavity of the acetabulum through its triangular shape. Okay. By grasping the head of the femur to maintain contact with the acetabulum. It enhances the joint stability not only by deepening the acetabulum but also by acting as a seal to maintain negative intra-articular pressure. The transverse acetabular ligament is considered to be the part of acetabular labrum, and the nerve endings within the labrum not only provide proprioceptive feedback but can also be the source of pain. This is about the acetabular labrum, and all these things forms the proximal articular surface. Now we will move on to the distal articular surface. The distal articular surface is formed by the head of the femur, and here in this pic you can see the posterior view of the proximal portion of the right femur. Okay, so and the head of the femur is covered by hyaline cartilage. The articular area of the femoral head forms approximately 2/3 of a sphere and is more circular than the acetabulum. Okay. So the femoral shape and dimensions were found to be variable even in bones of the same overall size. And if you see the radius of the curvature of the femoral head, which is smaller in women than in men, comparison with the dimensions of the pelvis, just inferior to the most medial point of the head, you will have a depression or a pit-like structure, a small roughened pit called as fovea or fovea capitis. The fovea is not covered with articular cartilage. At this point, a ligament is attached, namely ligamentum teres is attached to the head of the femur. Okay, the femoral head is attached to the femoral neck. The femoral neck is attached to the shaft. The head is attached to the neck and neck is attached to the shaft. Okay, in between the greater trochanter and the lesser trochanter. So normally the femoral neck is about 5 centimeters long, and the femoral neck is angulated. So the neck is angulated so that the femoral head faces medially. So it is facing medially, superiorly and anteriorly. So it is facing medially, superiorly and anteriorly. Okay, so and also if you see this facing with respect to the femoral shaft and the femoral condyles. That means the femoral neck is angulated, so because of this angulation, some angulations of the femur we can observe. Okay, so we can see this angulations of femur in the next session. So this is the main distal articular surface in the hip joint. The distal articular surface of the hip joint is the head of the femur, which is covered by hyaline cartilage. In the next session, we are going to see the angulation of femur, how this angulation of femur affects the stability as well as the position of the hip joint. Thank you.